Hello, my name is Roger Henderson. I'm a GP in South West Scotland, and I also co-host the GP Notebook study groups. Welcome once again to this GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, you can find us wherever you get your podcasts, including Spotify, Apple Podcasts and Google Podcasts, so do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. If you're on Twitter, you can follow us there at GPnotebook for more information about new episodes and study groups, and you can also visit GPnotebook.com for podcast episode show notes and to find out more about our upcoming study group meetings which occur throughout the year. Now, in this episode, I thought we'd discuss febrile seizures because I suspect you've all been asked about this in recent months. And a febrile seizure can basically be defined as a seizure that occurs in a febrile child, by which I mean one who has a temperature above 38 degrees centigrade, typically between the ages of 6 and 60 months, and who does not have an intracranial infection, metabolic disturbance, or a history of afebrile seizures. Now, as you know, the first occurrence is typically before 3 years old, but is infrequent in children who are younger than 6 months. And we can classify febrile seizures as simple or complex, depending on the clinical features, their duration, and any recurrence. So, simple febrile seizures are isolated, generalized, tonic-clonic seizures that last less than 15 minutes. They do not recur within 24 hours or within the same febrile illness, and there's complete recovery within an hour or so. Complex febrile seizures, on the other hand, have one or more of these features that differentiate them from simple seizures. A partial or focal seizure, which has movement limited to one side of the body or one limb, a duration of more than 15 minutes, there is recurrence within 24 hours or within the same febrile illness, or there's incomplete recovery within 1 hour. Now, between about 9% and a third of all first febrile seizures would be classified as complex in this way. It's also worth mentioning that febrile status epilepticus is a febrile seizure that lasts for 30 minutes or longer, or there are a series of seizures without any full recovery that last for 30 minutes or longer. Now, going back to 2006, there was a report by the International League Against Epilepsy Task Force on the classification and terminology of epilepsy and epileptic syndromes, which proposed a change in terminology and the omission of the words convulsion and convulsive. And they suggested that the term febrile convulsions should be replaced by febrile seizures. And this may be one of the reasons why perhaps we now use the term febrile seizure more than febrile fit, although the terms are often interchanged. Further changes in 2017 included replacing the term benign with self-limiting. Now, you might be thinking of other types of seizure related to acute illness in children, and you'd be right to do so, and these include things like febrile myoclonic seizures and afebrile convulsions in young children with mild gastroenteritis. And these have clusters of seizures with or without fever over several days in the setting of gastroenteritis. And the prognosis in these children is good. Now, we know that febrile seizures are common. The cumulative incidence is estimated to be between 2 to 5%, I think, in the US and Western European countries. And in some countries, especially ones such as Japan, there's an association with the season and the time of day, with more episodes occurring in winter and in the afternoons. Overall, febrile seizures are the most common form of childhood seizure that we see in our practices up to the age of 2. And viral infections triggering fever are the most common cause here, with bacteremia actually being an infrequent cause. However, we've got to say that about half of children who present with a febrile seizure have no identifiable risk factor that we can find, and a fever which triggers a convulsion may actually be from any cause, and this can include vaccination. Now, apart from viral infections, other known risk factors here include a family history of febrile seizures or epilepsy in first-degree relatives, the peak of the actual temperature itself, interestingly, whether the mother smokes or not, and any underlying neurological deficit. Now, obviously, age plays a really important role in the risk of febrile seizure, and we all know that the risk of recurrence of this type of seizure progressively declines with age. So, if there's an individual temperature threshold level above which a febrile seizure is triggered, then as that child grows older, the higher that threshold becomes, and so the lower the risk. Now, the diagnosis is made through a simple clinical assessment. We usually know what's going on here, but because of the obvious fact that we all look to rule out meningitis in these cases for obvious reasons, this typically drives our approach, and so investigations may take precedence. And in particular, infants who present with a suspected febrile seizure under the age of 6 months require careful medical evaluation, in my view. So, the typical patient tends to be from about 3 months to 5 years, but usually 12 to 24 months old, male, and presents with a fever that's followed soon after by loss of consciousness and generalized clonic movements and or tonic stiffening. Now, the seizure is commonly very short in duration, 3 to 5 minutes or so, with the recovery of consciousness being fast and without any sequelae, although the child may be drowsy afterwards. The temperature is generally very high. And as I say, a seizure that's focal or lasts more than 15 minutes or is repeated within 24 hours is classified as a complex febrile seizure. And we rely strongly on history here, don't we? So any history should include an eyewitness account of the seizure, as well as the consciousness level prior to the seizure, its duration, whether it was focal or generalized, the time taken to recover, and the state of the child afterwards. And for babies and young children, it's always the clinical examination rather than the history that's so important in detecting serious illness here, as the patient can't give a history, and so we have to rely on parents or other eyewitnesses here. Now, when we're assessing the child for symptoms of things like meningitis or septicemia, obviously we're looking for things such as a rapid onset of illness, abnormal crying, stiffness or floppiness, vomiting, and early symptoms such as leg pain, cold hands or feet, pallor, or skin changes such as mottling. In these cases, remember to check vital signs, levels of consciousness, whether there are any rashes, and these are either blanching or non-blanching, assess the fontanelle, and look for meningism, as well as for any focus of infection or signs suggesting another cause for the convulsion. Now, the first goal in treatment is control of the seizure. So during a witnessed seizure, the patient should be protected from physical injury, but do not restrain the child or put anything in their mouth. Check their airway and place the child in the recovery position when the seizure has stopped, observing the child until they've recovered. Check for any injuries that may have been caused by the seizure, but most will stop spontaneously within a very few minutes, and anticonvulsant therapy is not needed. If necessary, the body temperature should be reduced to relieve any discomfort or future risks of seizures. If the seizure lasts for more than 5 minutes, and obviously if you suspect meningitis or meningococcal disease or encephalitis or other things such as sepsis, call for an ambulance. If you've got a child with recurrent febrile seizures and whose specialist has advised this as a treatment for them, then give an emergency benzodiazepine such as buccal midazolam or rectal diazepam, and remember that these may be repeated once after 10 minutes if the seizure hasn't stopped. So let's have a look at some of the principles that guide us as to whether to admit a child immediately, arrange urgent hospital assessment, consider an outpatient appointment, or simply manage these children at home. So, if we look at immediate hospital assessment by a paediatrician first, arrange this if it's the first febrile seizure that child has had, or it's a subsequent febrile seizure and that child has not had a specialist assessment. If the child is less than 18 months old, we should do this, and remember that the clinical signs of infection may be hard to spot or absent in this age group. And also if the child has recently taken antibiotics, as these can mask the signs of a central nervous system infection. If you've any uncertainty about the cause of the seizure, if there's any focal neurological deficit, if there are any features of a recurrent complex febrile seizure, or if the parents are having difficulty coping or have extreme anxiety, then admit that child to hospital. You should also consider urgent hospital assessment for a period of observation if the child has unexplained fever and no apparent focus of infection. For outpatient referrals, consider this if an alternative cause for seizures is suspected, and I'm thinking of things like epilepsy or a neurodevelopmental condition here. If it's indicated due to parental concern, or if the child has neurodevelopmental delay or signs of things like a neurocutaneous syndrome or metabolic disorder. If the child has been assessed before for seizures, the child may be managed at home if they look well, if their parents understand how to treat febrile illness and any further seizures and are happy with this. And this includes when and how to seek urgent medical advice, such as serious symptoms like a non-blanching rash, lack of normal alertness, dehydration, the child getting worse, the parent becomes increasingly worried, or if there's fever for more than 5 days. Now, interestingly, there is no evidence that antipyretics reduce the number of febrile seizures. And although recurrence may be reduced by using some anti-epileptic drugs, the risk of adverse effects with these is high. And so, given the usually benign nature of febrile convulsions, any preventative medication should only be started by a specialist. Now, fortunately for all of us, the prognosis of febrile seizures is usually very good. These types of seizure don't recur beyond the age of 5 or 6, and there is no evidence for any increased risk of death linked to them, even for children with status seizures. They don't affect the intellect of any child who has them, although around 1 in 3 children will have a recurrence at some time following an initial febrile seizure. Now, the risk factors contributing to this include a family history of febrile seizures, an onset at a very young age, and a shorter duration of the fever at the onset of the seizure. However, between 2 to 6% of children with febrile seizures will go on to develop epilepsy with afebrile seizures, with this risk being higher in children with complicated febrile fits. So that was a quick overview of febrile seizures, and I do hope you found it helpful for the next time you see a child with this condition. But do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful, as always, if you'd consider following the podcast and leaving us a review on your favourite podcast platform. It really does help. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you've any questions, comments, or even ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you so much for listening, and goodbye.